Hello and welcome to this talk on psychotherapy for the non-therapist. My name is John Wurzel. I'm one of the faculty psychiatrists at Sacred Heart Medical Center and one of the faculty at the Psychiatry Residency Spokane. I appreciate you joining me today. During the course of this talk, we're going to discuss some of the basic principles of psychotherapy. We're going to review cognitive behavioral therapy in a little bit more detail, and we're going to focus on how we can use psychotherapy and psychotherapy principles in the context of non-therapy treatment settings, which might include the inpatient or the consult service, and it might include outpatient visits for other medical issues. So again, I appreciate you joining me, and let's get started. So there are a lot of different types of psychotherapy, some of them stereotypical, some of them less stereotypical. The earliest ones that we classically think of were Freudian-derived psychoanalytic psychotherapy, and psychoanalysis is kind of that stereotypical, the patient's lying on a couch, the therapist is asking them about their dreams, and the therapist gives very little away about themselves. Psychoanalytic psychotherapies are derived initially from the work of Sigmund and Anna Freud, and have been used for a century. They're not generally taught in psychology or psychiatry training these days. You attend a specific school dedicated to psychoanalytic training, and that generally takes multiple years of training in order to become proficient at. Psychoanalytic psychotherapies may or may not resemble the stereotypes that they used to be these days, but that's kind of where they come from. It's a very intensive form of psychotherapy to receive. It's a very intensive form of psychotherapy to be trained in. And it's a very unusual psychotherapy, so it's actually quite unlikely that any of your patients are going to be engaged in psychoanalytic psychotherapy. It typically requires attending multiple days a week for years, and very few insurance companies will pay for it, so it's generally a cash-only business. And because of that intensity, it also means that the therapists generally have very small patient panels, and so there's just very few people in the world receiving psychoanalytic therapy. There's psychodynamic schools of therapy, which was the next wave after psychoanalytic schools of therapy, and those include ISTDP, which is a short-term evidence-based form of psychodynamic therapy that we practice here at the Psychiatry Residency Spokane, but they also include multiple other forms of psychodynamic therapy, some evidence-based and others not. There are multiple types of cognitive therapy, multiple behavioral therapies. There is cognitive behavioral therapy, which combines the two. There are what's known as third-wave cognitive behavioral therapies, which are the descendants of cognitive behavioral therapy, if you will. There are therapies for specific indications. So social rhythms therapy is a treatment or an adjunctive treatment for bipolar disorder. Cooperative assessment and management of suicidality is a specific therapy targeted obviously to suicidality. Dialectical behavioral therapy is a therapy that addresses the symptoms often associated with borderline personality disorder. And so there's lots of types of psychotherapy, and they have multiple factors in common, and one of the most important things that they have in common is that the relationship between the therapist and the client is actually one of the most important predictors of positive outcomes. That doesn't mean that the relationship is friendship. It generally shouldn't be friendship. That's actually a different type of relationship. But it does mean that that relationship needs to be characterized by what's known as positive regard, in which the client feels like the therapist cares about them, generally sees them as a valuable and good human being, and has their best interests at heart. And means that the therapist feels those things. They care about the client, generally believes they're a good human being and a valuable member of the human race, and does have the best interests of the client at heart. There are evidence-based forms of psychotherapy, and then there are other forms of psychotherapy that are not evidence-based. And it's worth pointing out that the forms of psychotherapy that are not evidence-based are often not evidence-based because they're too difficult to study. So for example, psychoanalytic therapy, which like we said, often happens multiple times a week over the course of years, is very logistically difficult to study, but is also a highly individualized form of psychotherapy. And so the type of psychoanalytic therapy that one patient is receiving is often very different than the type of psychoanalytic therapy that another patient is receiving from the same therapist, let alone from therapist to therapist. And so it makes it essentially impossible to study psychoanalytic therapy as a unified entity. It's relatively easy to be able to say, oh, psychoanalytic therapy was effective in this patient and maybe not effective in that patient, but to talk about psychoanalytic therapy as a whole is essentially impossible to do from an evidence-based perspective. This is worth noting that the absence of evidence for a number of different types of psychotherapy doesn't necessarily imply that they're ineffective. Often it just implies that we don't know. Now, there are also forms of psychotherapy that have negative evidence bases in which they have been studied and have been shown not to work very well. Those are less common, though. There are a number of therapies that are evidence-based. They're generally short-term, right? And by that we mean on the order of a few months, generally. And they're all manualized, which literally means that there is a manual that walks you through how to provide this therapy. It says during session 1, this is the content you cover in session 1. During session 2, this is the content you cover in session 2, which allows for two things. One, it allows for fidelity. Right? So if we're studying cognitive behavioral therapy for insomnia, for example, we need to know that the cognitive behavioral therapy for insomnia that one patient is getting is the same as that another patient is getting in order to make a meaningful interpretation about the evidence base there. And a manualized therapy allows you to do that. It also means that it's relatively easy for the patients to participate by reading the manual, taking it home, doing homework out of the manual, etc. So it's very enabling. That said, it in no way means that the people actually doing or providing these evidence-based forms of psychotherapy are using the manual. It does call into question whether they're doing evidence-based therapy if they're not actually doing what the study did, but that's frequently the case. Generally, evidence-based therapies, which are the only ones we can study, are as effective as medications for mild to moderate symptoms of depression or anxiety, etc. And generally, the combination of psychotherapy and medications outperforms the treatment with either one alone. It's also worth knowing that therapy often works more quickly than medications, particularly behavioral therapies, in which you can go change your behavior tomorrow and potentially feel better because of it tomorrow or the next day. And that therapy often has more durable effects than medication. Medication really only lasts as long as you take it, where psychotherapy can help you develop skills that you can go and use even after the course of psychotherapy is completed. So we're going to look now at cognitive behavioral therapy in particular. And we're going to do that because it's an evidence-based form of psychotherapy that I believe is relatively easy to adapt to a number of different treatment settings. As I said, I've done cognitive behavioral therapy on the inpatient unit, on the consult setting. I've certainly done it in the clinic during therapy visits, but I've also done it in the clinic during a primary care visit, for example. And so cognitive behavioral therapy has a lot of flexibility and is relatively easy to learn. And so let's discuss some of the particulars about CBT. This is typically performed every week or every other week over a course of a couple months. Now, I can already hear the primary care docs and future primary care docs saying, well, I don't get to see my patients that frequently. And we'll circle back to this idea, but I would propose that if seeing a patient every other week for 2 or 3 months is enough to help them manage their insomnia, for example, to the point that you no longer need to have a conversation with them every time you see them about Ambien or temazepam, etc., then it may actually be worth going out of your way to make the time to see them that frequently for CBT for insomnia. Now, CBT can be used for a lot of different indications, including the ones we're going to discuss as we go through this, but a lot of other indications as well, so I don't want you to think this is exhaustive. is based on the premise that cognitions, behaviors, and feelings are linked together, and that we can change how we feel, which is the treatment target, by changing what we think or what we do, and we'll talk a lot more about this in a bit. So it's worth knowing that while both the cognitive aspect and the behavioral aspect of CBT are effective, the behavioral aspect probably has a greater average impact, is faster to deploy, and is often easier for some patients to learn, particularly if they have some cognitive impairment. So like I said, when I think about using CBT in the primary care setting, I think about using it for patients with mild to moderate depression, anxiety, or insomnia, and I really consider it to be effective. The evidence base shows that it is, and practically doable. I generally recommend a 45 to 60 minute appointment initially, and then 20 to 30 minute appointments every other week for a few months, which, like I said, is more time consuming than typical care, but may well be less time consuming than debating about benzodiazepines or non-benzodiazepine sedative hypnotics at every appointment for months or years, or in some cases, unfortunately, decades. And, unlike medications, as we said, the effects of CBT can last for years or more. So we'll revisit this once we review the specifics of how to do CBT, and hopefully you'll be able to see how, I could potentially deploy this in the clinical setting for some patients. I also want to throw out that this, as we go through this application of CBT, we're really going to focus on the behavioral interventions. If you feel like your patients need cognitive interventions, I actually feel like that probably pushes them outside the scope of patients who could reasonably receive this treatment in a primary care setting. The cognitive interventions tend to take longer to teach the patient, and also take longer for the patient to incorporate and benefit from. And so I think that primary care would be too time limited to do useful cognitive therapy. And so if that's the case, I would probably refer them to a dedicated therapist. Also, as I say here, I really consider this reasonable in the primary care setting for patients with mild to moderate symptoms. If they have severe symptoms, I would again refer them to a therapist. Before we jump into discussing the details of how to provide behavioral therapy, I want to take a step back and look at the enormous importance of psychoeducation. And I consider this to be true for cognitive behavioral therapy, but also for really any recommended intervention, whether it be therapy, whether it be a medical intervention, a medication, physical therapy, rehabilitation, anything like that. The most difficult part of cognitive behavioral therapy is getting the patient to actually engage in behavioral change. And that's probably the most difficult part of, for example, helping someone manage their diabetes as well, or helping them recover from a surgery. And there's a few strategies that I want to discuss in terms of helping our patient to do what's actually in their best interests, medically speaking. So the first one is goal alignment, right? It is very important for us to recognize that when we're seeing a patient, we have some fairly specific short-term goals. We want to make an accurate diagnosis and make appropriate treatment recommendations. That's what we have years of training to do, and it's what makes us feel successful in our efforts. We also have long-term goals, which hopefully align with the patient's goals to accomplish whatever it is that they want to accomplish with their life, be a good parent, a productive member of society, be able to go travel, win the swim competition, whatever it is. We ultimately want our patients to accomplish their goals, and our medical recommendations are in service of helping the patients to accomplish their goals. But that's not always immediately clear to our patients. And so the patients often walk in with a certain set of goals that are not the same as the goals that they sense their physicians having, accurately sense their physicians having, which focus around diagnosis and treatment. And so it's our job to help the patient understand that we're trying to serve their goals. It's our job to explore their goals with them and then to frame our recommendations in such a way that they understand how those recommendations will move them closer to their goals. And if in fact those recommendations don't move them closer to their goals, then we need to revise our recommendations. So, as an example, if we have a patient come in who is very concerned about his family and his ability to be there for his daughter, and he's telling you that taking his insulin is constantly pulling him out of family meals or pulling him out of conversations that are really important to him, and he doesn't want to miss out on that, then part of the barrier to him taking his insulin is likely that we're discussing two different goals. And as the physician, it's our job to say, so your family is really important to you, and we want to create a situation where you're the best father, husband, son that you can be. And in order to do that, we have to think about your insulin regimen in that context. So you want to be here for your family for as long as possible, and you want to be as functional as possible. And so we know that, on the one hand, taking your insulin can interfere in these short-term activities, and on the other hand, it can help prevent you from going blind or developing renal failure or needing amputations, and can therefore help you be engaged with your family for that much longer of your life. Now let's discuss this decision in that context, right? So if we can align our recommendations with the patient's goals, they're much more likely to engage in them. Another major factor in helping people to do the things that they need to do to get better is psychoeducation, or just education in general. In this case, we'll discuss it in a lot more detail over the next couple slides, but it's critically important that the patient understand why they need to do what you're recommending in order to get better, or why they might consider doing what you're recommending in order to get better. If a patient comes in looking to feel better and walks out with homework, that does not feel like very good goal alignment, and so it's our job to help them understand how that homework serves their goal of feeling better. And ultimately, if this all sounds like motivational interviewing, well, that's because motivational interviewing can play a huge role in successful cognitive behavioral therapy. So if the patient isn't engaging in whatever the recommended treatment is, the first thing you want to do is explore any concrete barriers that just need to be troubleshot, right? But assuming there are no concrete barriers, then you want to look from a more motivational interviewing perspective at, again, goal alignment and how can we help the patient move from sustained talk into change talk around whatever behavior it is we're discussing. So I'm now going to walk you through exactly what I walk patients through in an effort to do psychoeducation and goal alignment. So if you were my patient and you came in and we had our initial intake and I got a sense of things and I was thinking, cognitive behavioral therapy might be a good option for you, this is roughly what I'd say. So you're here because you want to feel differently, right? And unfortunately, none of us have switches installed in our brain that we can just throw and it'll change how we feel. If we did, I'd be unemployed, but I'd be happy about it because I'd just throw the switch. So our target is to change how we feel. Now, I've got this proposal, this type of psychotherapy that's based on the idea that how we think and how we behave can change how we feel, and that all of these things, our thoughts, our feelings, and our actions, are all interconnected with these sort of double-headed arrows where our feelings can influence our thoughts and vice versa, and all the way around. And so that's the idea. Now, I don't know whether this will apply to you or not, and in a minute we're going to run a couple thought experiments just to see whether this seems like it might work. But this is the idea. All right. So that's my spiel, that's my introduction, and the things that you'll notice, first, I really clearly acknowledge and align with the goal of changing how the patient feels. And then I want to provide them the education that the way I'm proposing that we go about changing how the patient feels is changing how they think or how they act. And I'm not telling them that this is true. I'm setting it up as an experiment, which I think is a really important skill or a really important frame. You don't have to do that, certainly, and I don't with all patients. But with a lot of patients, particularly those who are cognitively intact, I want to propose that they discover for themselves whether this works or not. I always actually draw this triangle and write in the thoughts, feelings, and actions boxes. And I'll tell you a quick story. I had a therapist who I was working with and helping to train. And she was a good CBT practitioner. She was good at providing CBT for her patients. But she didn't like the triangle itself very much. And there was one day where I was in her office and I was teaching medical students. So I drew the triangle and left it on the board when I left. And the next time I saw her, she said, damn you, John. And I was like, what'd I do now? And she said, that triangle of yours, you left it on the board. And the next morning, my patient came in and we started session. And the very first thing he did was open his notebook and he copied the triangle down and started asking me, was this what I was talking about? So I tell this story because I like the triangle, and visual aids can be really important. And so I encourage you, if you're going to do this, draw the triangle. It will help your patient understand and hold on to, although we're targeting your feelings, we're doing it by more directly targeting your thoughts and your actions. All right, so now we're going to go into the thought experiment. So what I want to do, I'll say to my patient, is run a thought experiment and see if this holds up. So I've proposed that we want to change how you feel, and maybe we can do that by changing how you think and what you do. But let's see if that's true. So we're going to pretend that we have a patient with depression. So I'm going to start by saying, so let's say you wake up, it's a Saturday morning, you wake up, you're lying in bed, how are you feeling? And they're probably going to say, I feel depressed, I feel sad, I feel hopeless. If they don't say those things and they've already said them during the course of our intake interview, then I'm going to copy those down. And ideally, what I want is the patient writing this down. So I'm going to draw this triangle on a piece of paper. I'm going to sit next to the patient and we're going to look at the paper together. I'm going to give them the pen and I want them writing this down because that'll help them take ownership, which will again increase their engagement. So you wake up on a Saturday morning, you're lying in bed, how are you feeling? I feel depressed, I feel sad, I feel hopeless. Okay, what kind of thoughts are going through your mind? Well, I guess I'm thinking, nothing ever gets better, and there's no point, I'm useless, those sorts of thoughts. And again, if they're not volunteering them, but I've already heard them from them, I'm going to write them down. I really do want quotes as much as possible here. Okay, so you're lying in bed, you're feeling sad and depressed, and you're thinking, nothing ever gets better, what's the point? What are you likely to do? Well, last time I was in that situation, I just stayed in bed and I watched Netflix all day. Okay. Now, at the end of the day, you've been feeling depressed and sad and hopeless and thinking nothing gets better, and you just laid in bed, didn't take a shower, didn't get out of your pajamas, watched Netflix. At the end of that day, how do you feel? Well, I feel lousy. Do you feel worse than you did in the morning? Yeah, maybe a little worse. Okay, so if I'm understanding this right, you're feeling depressed and sad and hopeless, and that's leading you to think, nothing gets better, there's no point. And as a result of that, you're staying in bed and you're watching Netflix. And that's making you then feel even more depressed and even more sad and even more hopeless. And the next morning, on Sunday morning, you're feeling a little more sad and depressed and hopeless. Are you more or less likely to think that there's nothing gets better and there's no point? I guess I'm a little more likely. Okay? Are you more or less likely to stay in bed? Right? So we walk through this, and then I'm going to say, okay, so what we've discovered is that we can change how we feel based on what we think and what we do. We've managed to figure out how to feel worse, which is the wrong direction, but we can change how we feel, so at least that's good news. Let's see if we can change how we feel in the other direction. Alright, so here we are, we're lying in bed on a Saturday, we're feeling sad and depressed and hopeless. We're thinking nothing gets better, there's no point, I'm useless, and so we're debating, we're thinking maybe we should just stay in bed and watch Netflix. But instead, we decide, no matter how lousy I feel, I'm going to get out of bed and take a walk today. Okay. So, you're feeling sad and depressed and hopeless, thinking nothing gets better and there's no point, but you get out of bed and you take a walk. Now, while you're on this walk, what kinds of thoughts are you having? How easy is it to maintain the thought that nothing gets better if you're on a walk? Well, maybe I think it's a little better. Okay, how easy is it to maintain the thought that you're useless when you just got out of bed and put on some clothes and went and took a walk? Well, maybe I think I'm a little less useless, but it's just taking a walk. I mean, it's not like I went to work or anything. No, I know. It's just taking a walk. But you feel a little bit better. A little better. Okay. And then, while you're on this walk and after you get back from this walk, do you feel more depressed, sad, and hopeless, the same, or less? Well, maybe a little less depressed and sad. Okay. And then, come Sunday morning, you're feeling a little less depressed, thinking, maybe I can get a little better. Are you more or less likely to get out of bed and take a walk? I guess I'm a little more likely. Oh, okay, and then the cycle continues, right? So we can actually change how we feel for the better by changing what we do or changing what we think. At least in this thought experiment. Alright, so we'll take a break from my spiel to the patient. So, a couple notes. The first thing, you'll notice that I focused on changing what people do. Now, changing what people do, the action rather than the thought, is very difficult. If it was easy for them to take a walk, they'd be taking a walk already. But it's easier to identify, and it's a more immediate intervention than trying to change on what they think, which requires a lot of practice catching the thought, a lot of practice restructuring the thought, and a lot of practice then replacing the thought. So that's why I focus on changing the action. The other thing is occasionally you'll get patients who are either telling you, it makes no difference, I still feel depressed, sad, and hopeless, it doesn't change how I feel at all. And so there's two possibilities there. One is that they're telling you the truth, and maybe this isn't the intervention. So, I tell my patient, we've figured out that, at least in theory, we might be able to change how you feel by changing what you do. In theory, but in theory only helps you so much. You're here because you want to feel differently in reality. So, I think what we need to do is figure out if this will work for you. I want to run some real experiments. I mean, maybe getting out of bed would work, and maybe it wouldn't. We should find out. I know that everyone can potentially benefit from different behavioral interventions, and we're not going to know which ones are going to help you without running the experiment. So, what we need, I think, is a list of behavioral changes that might work. And then what I want is to help the patient make a list, in no particular order, of behavioral changes that might work. Often, patients will sort of get where we are from this point, and they'll just start generating a list. If not, here's some questions that you might ask to help the patient generate a list. Well, what do you enjoy doing now? Because if you enjoy doing it now, there's a pretty good chance you'll continue to enjoy doing it. And if we do it more, maybe it'll bring you more joy in your life. What did you used to enjoy doing before you became depressed? Because it's possible that if you go back to doing that, it'll help you stop being depressed. Right? For patients who don't have quite enough from either of those things, well, what can you imagine enjoying? Or what do your friends or family seem to enjoy doing? I've even gone so far as, what do people on TV or people in the movies seem to enjoy doing? You really want the patient to volunteer the ideas. If they have no ideas at all, only then should you make suggestions. Because if the idea comes from them, they're much more likely to actually try it than if the idea comes from you. Again, if your patient's cognitively impaired and they're really getting stuck on this, then I have a much lower bar for making suggestions. But in general, if there's someone who's cognitively intact and have no ideas about what might help them feel better, I would again look at, is this an effort to communicate how bad they feel to me? Do I need to validate that? Or are they genuinely unable to come up with ideas? Alright, so now you have a list, right? And I'm going to look at the patient, I'm going to say, well, we've got this great list. What do you want to try? What do you want to try first? And what I want is for the list to be organized from essentially the easiest thing to try to the hardest thing to try. If they're like, you know, what I think would really make me feel better is taking an 80-day trip to the Far East, most people, that's going to be at the very bottom of the list because it's not a very useful experiment unless they're very wealthy and you feel like taking an 80-day interruption in the therapy is the right next step. You know, most of the time we want things that are easy to do, easily accessible, and fairly time limited so that we can get rapid feedback on whether the intervention works. And so I literally make a list that looks just like this, and there is a Word document that accompanies this lecture that has an example list you can just print out and have the patient populate, right? And so again, I'm going to have the patient do this if at all possible, and I'm going to be like, let's translate this unranked list that they just made of things that might make me feel better into a list of things that might make me feel better, organized by easiest to do to hardest to do. And then I'm going to ask them, okay, we've got this list. Well, what are we going to do with it? We're going to turn the list into a series of experiments. And I'm going to tell the patient, you know, in order for an experiment to be valid, we have to be able to replicate it, which means we need to be able to measure it, right? And so we're going to start with whatever was number one on the list of easiest, most accessible behaviors. And what we need to do is turn this into a measurable thing. So if your behavior is, for example, taking a walk, well, if the behavior itself is to take a walk, and you walk to the mailbox and back, did you take a walk? It's ambiguous, right? Which creates a couple issues. The first issue is that they don't get to give themselves credit for having done it. There's no sense of satisfaction associated with maybe having taken a walk. There's a sense of satisfaction and accomplishment associated with having taken a walk, particularly if that was your goal for today. So that's problem number one. And problem number two is it makes it very hard to do a valid experiment to see if it actually made you feel better if we don't know whether you even did it or not. So it's not that walking to the mailbox can't qualify as taking a walk. It absolutely can. We just need to know whether it does or not. So I always say, how long a walk? Let's make it a 15-minute walk, or walk around the block 4 times, or I'm going to walk for 2 miles. I need some numeric measurement that they can use to decide whether they've done it. And then what we're going to do is, just like it looks like on this sheet, we're going to say, okay, well, over the next week or 2 weeks, depending on when you're going to see them again, behavior 1, take a walk. All right. The first time I try it, they're going to fill in the date, and then they're going to write down the mood they're experiencing before, and the mood they're experiencing after, and how much it changed. And the way I want them to record their mood is on a scale of 0 to 100. So 0 being the most depressed one can imagine being, 100 being absolutely feeling great, not manic, just great, normal mood, right? The ideal mood. So on a scale of 0 to 100, we want you to write down, how did you feel before you take the walk? Then you go take the walk, and then write down immediately afterwards, how do you feel afterwards? And then, simple math, how much did it change? And we're going to try that a number of times over the next couple weeks, as you can see. And then the second behavior on the list, let's say it's call a friend. Again, we need to quantify calling a friend. I'm going to call a friend and talk to them for at least 10 minutes. Okay, that's calling a friend. All right, so we're going to try that 4 times over the next couple weeks. And then behavior 3 is go to a coffee shop. All right, and we're going to go to a coffee shop and stay as long as it takes to drink my coffee. All right, that's fairly quantifiable. We're going to try that 3 times over the next couple weeks, and for each of these we're going to record our mood before, our mood after, and how much our mood changed, right? And this is literally a bunch of experiments. So I want you to go do this thing, and then come back in 2 weeks with your data, and we're going to discuss what we learned and how we can adapt it to help you feel even better. I want to walk through now each of these sessions individually. As I said earlier on, cognitive behavioral therapy is manualized. I'm not going to walk through the manual, although I encourage you to buy the manual if you're doing a specific kind of therapy multiple times. They're relatively inexpensive. The Treatments That Work series of cognitive behavioral therapy manuals is very useful. Has a lot of the forms that you can print out for the patient to fill out or photocopy for the patient to fill out. And it's useful just to remind you kind of how to go through this. But I'm going to generally go through the sessions from a big picture perspective. So during the intake session, you're going to primarily be focusing on a diagnostic interview, figuring out what's going on with this patient and how we can best help them. Assuming that you determine cognitive behavioral therapy or behavioral therapy is an important part of the intervention, then this is when you do all that psychoeducation that we already talked about, because you've got to generate buy-in. You need to align your proposed treatments with your proposed treatments with the goals of the patient, and then you want to do some motivational interviewing to help them actually engage in running these experiments. During your intake, you're then going to turn to generating your list and turning your list into a behavioral plan. So that's exactly what we've talked about so far. at your follow-ups, you're going to start with a 5-minute check-in, generally, how was the last couple of weeks? And then you're going to review the behavior plan from the last session. Now, ideally, this takes 10 minutes-ish, but it depends on how it went. And the key, especially at the beginning, is to reinforce the connection between behavioral change and feelings. So every time I'm looking through this behavioral experiments chart that they have brought in, you want to have them bring that chart in with them, right? I'm going to be like, oh, so you took a walk and it made you feel better that day. It made you feel a little better. That's great. And then on this day you took a walk and it didn't make you feel better. But on this day you took a walk and it did make you feel better. I want to drive that connection because that's the core of these behavioral interventions. So we're going to take 10 minutes or however long it takes to review the behavior plan and really treat it like a valid experiment, assuming that they did it. If they took a walk 5 times and it didn't help them feel better, then we're going to say, that doesn't seem to have worked. We need to try something else. Let's switch to a different set of experiments with a different behavior. Ideally, I want them to tell me what they learned, and if they can connect those dots between actions and feelings, then all the better. We're going to take 5 minutes to review psychoeducation, which often just is me again repeating, oh, you changed what you did, and look, it changed how you felt. And then maybe 10 more minutes developing the next behavioral plan, right? So how are you going to plan out the next couple weeks? We've got some good data here. How are we going to apply it to the next couple weeks? Again, I'm going to print out or give the patient a new behavioral experiment sheet. Again, I want them to populate it themselves if they can. Again, we want to be concrete and specific. We want to take what we learned and use it again. So if it turns out that taking a walk did help, then we want to keep taking walks. That kind of begs the question, well, how long do we leave things on this behavior plan? And the answer to that is until they stop changing the person's mood. So at a certain point, your patient's going to be engaging in things to such an extent that taking a walk doesn't really impact their mood anymore. And then you drop it off the behavior plan and you replace it with another behavior. And what we really want to do is kind of march our way down that ranked list that we made with them, where we do, lots of item 1, a little bit of item 2, and a few of item 3, until they get as much benefit as they can out of those, and then we drop item 1, promote items 2 and 3, add item 4, and we keep working our way down that list. And the other possibility is that they're now automatically taking a walk, 5 days a week or every day or whatever, and so leaving it on the list isn't really serving much purpose, so then we take it off the list to make room for something else because they're already just engaging in that behavior. They will largely drive this. Now, as you can imagine, the challenge here is getting them to do the behavior change. It is fairly self-reinforcing once they start doing it, particularly if you or they, ideally, are connecting their change in behavior to their change in their feelings. They'll realize fairly quickly, I take a walk, I feel better, I should go take a walk. I call a friend, I feel better, I should call a friend. And particularly if you're good about treating these like valid experiments, then the patient will rapidly discover, oh, I can figure out how to make myself feel better. That's what the therapist is trying to do. They're not just leading me to the answers that they want me to arrive at. We're actually running these experiments together to figure out what works. Great. Let's keep doing it and see what works. And so my experience is, you have your intake, you have a couple or a few sessions where you really have to do a lot of motivational interviewing to get them to engage. And then they start to engage. There's a couple of few sessions where you're helping them Now let's look at adapting the same set of principles to anxiety treatment. So we'll walk through this more quickly because it really is almost identical except for the core feelings, thoughts, and actions. So again, I've got my patient come in, I draw the triangle for them, I tell them, we're proposing this idea that we can change how we feel, which is your goal, by changing what we think or what we do. And I want to turn it into a thought experiment. So let's say that you are socially anxious, right? And you're thinking about going to a party. How do you feel as you think about going to the party? Well, I feel anxious. I feel scared. I'm just frightened. Okay, and what kind of thoughts are going through your head? Well, I'm thinking, I can't go to this party. Like something bad will happen. What if people judge me? What if people laugh at me at the party? Okay, so what do? You're feeling anxious and scared. You're thinking, what if people judge me? I can't do it. What do you do? Well, I don't go to the party, right? Okay, so you avoid the party. Yeah, I avoid the party. And how does that make you feel? It makes me feel better. Yeah, it does make you feel better in the short term. Absolutely. And the next time you're thinking about going to a party, does it make you feel anxious and scared to think about going to the party? Yeah. And you're having those thoughts about, I can't do it. Do you have evidence that you can't do it now? Well, yeah, I couldn't do it last time. I didn't go to the last party. Okay, so you're more likely to think you can't do it. And you're more likely to avoid. And that's more likely to help you to feel anxious and scared, etc. So again, I'm going to walk them through the development of this cycle. It is important to acknowledge that avoidance, which is the universal behavior associated with anxiety, pretty much all anxiety leads to avoidance as the behavior. Avoidance makes people feel better in the short term, but it teaches them that they can't do it in the long term, and it increases their anxiety in the long term. And so you have to acknowledge that it can help them feel better in the short term and point out that it can make them feel worse in the long term. And then I walk them through the cycle, progressing again. All right. So I say you're feeling anxious and scared, and you're thinking, I can't do it, it's dangerous, what if people make fun of me? You're thinking about avoiding. But I want to propose, again, this thought experiment. What if instead of avoiding, you go to that party? Now you're at the party. How easy is it to maintain the idea that you can't do it? You obviously can do it. You are literally there, right? And how easy is it to maintain the idea that it's dangerous when you are there and not actually in danger, right? So it makes it harder to maintain those ideas, easier to think, well, I am doing it, and I guess it isn't dangerous right now, at least. And as you think I am doing it, and it isn't dangerous right now, as you think about going to the next party, how do you feel? Well, maybe slightly less anxious, slightly less scared. Okay, and as you're thinking about going to the next party, is it easier or harder to decide to go to the party? Well, maybe a little bit easier. Okay, so it's a little bit easier, and then you go to that party, and again, you're thinking, I am doing it, and we have this positive cycle. So it turns out that with anxiety too, if we change what we do, in theory, we can change how we feel. Again, we want to turn the thought experiment into a real experiment, right? And so just like for the depression, everyone's going to benefit from different behavioral changes. We can't know which ones are going to help without running the experiment. And I'm going to frame this as an experiment. I'm like, okay, so we ran this thought experiment, and maybe we can help you feel less anxious, which is your goal, by changing what you do. But we don't know yet. So we've got to actually develop some real-world experiments to find out. And if what we're proposing is doing the things you would usually avoid. Well, we need a list of things you would avoid. What things make you anxious? So again, most patients will volunteer this, but we want, what are the things that are currently frightening to you? We want a list of physical exposures. We may want to think about visual exposures, looking at pictures, watching videos. If they have, for example, a specific phobia of snakes, then you can look at pictures of snakes and watch videos of snakes, maybe as a step before the physical exposures if those physical exposures seem too overwhelming to start with. You may even want to do imagined exposures, so even before you look at pictures and videos, let's just think about snakes or talk about snakes first, right? So we need, again, a list of things that cause anxiety. Then we're going to ask the patient to organize it from the least scary thing to the most scary thing. And then we're going to ask the patient to take that ranked list and turn it into a series of experiments. Again, we want concrete, measurable behaviors. So if the thing that is, if they have social anxiety, we'll go back to that example, and the behavior they've chosen is to talk to more people, that's too vague. So a concrete thing might be, I'm going to say hi to a stranger in line at a coffee shop. Great. So saying hi to a stranger in line at a coffee shop, that's the behavior. We want to measure how anxious we are about saying hi to a stranger in line at a coffee shop before, how anxious we are about it after, and how much our anxiety has changed. Again, we're going to use this scale of 0 to 100. We're going to do it multiple times. We're going to record it each time. The second behavior might be call a family member who, talking to that family member makes them anxious. Call a family member is the behavior. Ideally, we'd want to talk for a certain amount of time, but, some of that is outside the control of the patient, depending on when the family member. How many times are we going to try it? Over the next couple weeks, we're going to rank our anxiety after, see the change, etc. I want to point out that there's a couple different things to think about. So there's the idea of desensitization and the idea of extinguishing. Now, extinguishing, if you remember from your neurology, extinguishing is essentially when a neuron fires so many times that it stops being able to fire. Whereas desensitization is when the action potential threshold goes up that a neuron stops firing. If we apply these concepts to sort of anxiety and exposure therapy, all exposure therapy is desensitization work, and that's a long-term perspective. What we want is for the threshold of anxiety to go up to the point where anticipating the next experience is no longer anxiety-provoking. It's the long-term perspective. So I'm going to go talk to a stranger at a coffee shop until talking to a stranger at a coffee shop no longer makes me anxious, or more accurately, until thinking about talking to a stranger at a coffee shop no longer makes me anxious. I'm going to give enough presentations at work that giving a presentation at work or thinking about giving a presentation at work no longer makes me anxious. That's desensitization. That is the core of all exposure therapy. There's also, some people do sort of extinguishing work, where you are going to sit in the anxiety-provoking experience to the point where you stop feeling anxious in the moment, right? So if you're afraid of elevators, you're going to stay in that elevator until the anxiety passes. That is not necessary, but it can be very helpful. So standard exposure therapy in my mind for a fear of elevators would be you get in the elevator, you get off the elevator, you get in the elevator, you get off the elevator, and you repeat until getting in and off the elevator or riding the elevator, whatever it is, no longer makes you feel anxious. The extinguishing twist is you get in the elevator and you sit with it until you don't feel anxious, and then you get off and you get back on and you sit with it, etc. That's not necessary, like I said, but it can be helpful. It segues to an important point about this list, though. We want them to rank their anxiety before doing whatever makes them anxious and after, in anticipation of doing it again. But ranking their anxiety in the middle of it is not going to be productive. Of course they're more anxious in the middle of it. The goal is to decrease their anxiety about doing this, and that will in turn decrease their anxiety when they are doing it. But it's an important distinction to make for the patient. So what I tell the patient is, I need you to tell me, how anxious do you feel before you give this presentation? And then after you give this presentation and think about giving another presentation, how anxious does that make you feel? And that's the change that we're looking for. What if something bad happens? So if it was something that was genuinely dangerous or damaging, the patient got assaulted or arrested, then we need to validate, of course, and we need to problem solve, and we need to reinforce that there's a clear line between doing things that make you feel anxious because you have pathological anxiety and doing things that make you feel anxious because they're legitimately dangerous. Anxiety does play an important protective role. So I always tell my patient, the general concept is that you do things that make you feel anxious to feel less anxious about them. But if what makes you feel anxious is walking down a dark alley at 3 a.m, you should feel anxious about that, and I would recommend that you not do that, right? And so, regardless of whether what they were doing was something we would recommend them doing or not, if they did it and something bad happened, especially if it was genuinely bad, then we really need to validate them, help them problem solve, etc. If it wasn't genuinely dangerous or damaging, then that's a situation where we want to cheerlead. So for example, they were scared that people would judge them, and people did judge them, right? I'm going to be like, I'm so sorry that happened, but that's actually great news, and this is why. So first, you did the hard work of running the experiment. And second, look at you, we're having this conversation. The worst case scenario happened, and you're okay. You can go back into that scenario and know that even though you might get judged, even then you're okay. Probably you're not even going to get judged, but even then you're okay, right? And let's look at this from a bigger picture perspective. How scared are you about being judged now compared to how scared you were about being judged before? And what's the change in our anxiety there, right? And so actually having something mildly bad, quote unquote bad, happen is an important part of exposure work because it helps them realize that they're catastrophizing about worst case scenarios. Even if someone at that party made some comment that made them feel uncomfortable or hurt, they're still okay. And we can help them problem solve how not to feel uncomfortable or hurt, or if appropriate, how to respond to that kind of comment in the future, etc. So we both want to give them concrete tools, and we want to help them understand how this was still a valuable learning experience. In fact, it may have been an even more valuable learning experience for them. So we've been talking about anxiety as if it was a unified concept, and obviously it's not. There's a lot of different kinds of anxiety, and appropriately, there's a lot of different kinds of exposure work for those different kinds of anxiety. So we'll start by talking about specific phobias, which is kind of the paradigm that we've already discussed. They're treated just like above. Sometimes you might need to use those imaginal or visual exposures before you move on to physical exposures. They're treated just like above. Social phobia is really just a subset of specific phobias, and we used it as an example as we were walking through the process above, and so again, treated just like above. When we look at generalized anxiety disorder, if you try to do exposure work for generalized anxiety disorder, you'll rapidly discover that first, it works. Generalized anxiety disorder responds to exposure therapy. But the second, you often have a situation where there are new targets that pop up as you address each target. Generalized anxiety disorder is characterized by worries about multiple different aspects of one's life. And so we often see that once the patient's able to get one aspect of their worries under control, another one pops up, and it feels kind of to them and to us like playing whack-a-mole. And so the goal is not to target each of those individual things until they run out of targets. The goal is to help the patient internalize the process, the tool of exposure work, so that they can learn how to manage their anxiety effectively. So they can take this tool and use it to target those issues that feel like it's worth targeting as they pop up in the future, which they're very likely to do. You're not going to whack all the moles with the patient, but you can teach them how to whack the moles themselves. It's also worth knowing that generalized anxiety disorder is characterized by a lot of cognitive distortions often, a lot of catastrophization, and a lot of jumping to conclusions, those sorts of things. And that aspect we typically treat with cognitive restructuring work, which is the cognitive aspect of cognitive behavioral therapy. And as I said earlier, I think cognitive restructuring work is largely beyond the scope of a primary care doc, and so would merit a referral to a therapist. If we look now at panic disorder, there's kind of two possibilities in panic disorder that can also coexist. One is that the patient has panic attacks triggered by a specific issue. And if that's the case, then you can do exposure work around that specific issue, just like any other exposure work we've already talked about. You help the patient to tolerate the panic attacks, but otherwise you target that trigger just like any other exposure target. The other is that, especially in classic panic disorder, what the patient is anxious about is having panic attacks themselves. And the way that you would manage anxiety about panic attacks, as you might imagine, is by having panic attacks and realizing that although they're very uncomfortable, they're actually not dangerous, and they can be sort of treated as an irritant. The example I like to give is it's like stubbing your toe. It's really sort of blindingly distracting, but it's also something that you just ignore as best you can and get on with your life. Triggering panic attacks in order to do exposure work in having panic attacks is called interoceptive exposure, and that's probably beyond the scope of primary care. So if there are targets that you can identify outside of the panic attacks themselves, that may well be something you can help someone with in primary care setting. But if it's the panic attacks themselves and you think they need interoceptive exposure, I probably would refer them to a therapist. For post-traumatic stress disorder, evidence-based therapies include prolonged exposure therapy, cognitive processing therapy, and eye movement desensitization and reprocessing therapy, or EMDR. These are all forms of exposure therapy. The amount of groundwork required for a patient to successfully be able to do any of these forms of therapy, the intensity of the therapy and the frequency of the therapy all require specialized training and a higher level of care than primary care, and so I think all of these would merit referral to a therapist. In terms of obsessive compulsive disorder, the treatment is exposure and response prevention therapy, and it is really exactly what it sounds like. It is a process in which you help the patient to expose themselves to whatever it is that triggers their OCD symptoms, and then to tolerate restraining from their typical response. So if, for example, a patient has a ritualized hand cleaning compulsion after they touch something that's potentially dirty, then you're going to help them to repeatedly touch things that are potentially dirty and to refrain from washing their hands and to eventually internalize the idea that they don't need to wash their hands in that setting over and over again in order to be safe. Now I want to tell the story of one of my patients as an example that I think illustrates a number of the concepts that we've talked about in terms of exposure therapy. So this was a lady who was in her early 40s, and she had been in a relationship characterized by domestic violence multiple years prior, got out of that relationship, and had then really just retreated into her house and had been a shut-in for 2 to 3 years before we met. She left her house once a week with her mother for half an hour to shop for groceries. She lived with her mother and her daughter, and other than that, didn't leave her house at all. This had a lot of consequences for her. She was obviously unemployed. She had no meaningful relationships outside of those with her mother and her daughter. She felt like she was a terrible example for her daughter. She was depressed and anxious because she wasn't leaving her house. She was morbidly obese because she got essentially no exercise, and she really wanted to address that. And so she had a lot of things that this lifestyle and that her anxiety had led her to want to work on. And so she came to see me. Now you can imagine that even just coming to see me, a stranger, and a male stranger in the context of this previous domestic violence with a man, was a real important step in the first place. We sat down, discussed her case, and she decided that it sounded like maybe this exposure therapy would be worth giving a try. She wasn't real convinced, and so in a very kind of classic way, she and I spent probably a month. She was a fairly severe case. We probably spent a month talking every week before she was really willing to even try doing exposure work. And then another 2 or 3 weeks of her testing it out and seeing if it seemed to help at all before she discovered that the more often she took a walk, the less anxious she was about taking walks. And so within about 6 weeks, she was able to go from leaving the house for half an hour a week to taking a walk every day. She started to look at talking to strangers on the walk, just briefly saying hi as she passed them, and started to incorporate that. And then she came up with the goal of saying hello to people in line at coffee shops. And she really got stuck there. And for multiple weeks we talked about it, and she just couldn't overcome her anxiety. And so we agreed, with a fair amount of urging on my part, that we would try an in-session exposure where we went to the coffee shop in the hospital where my clinic was together during session, and she would say hi to the barista and maybe someone in line, and we'd see if that helped. So she and I rode the elevator down. She had a panic attack in the elevator, was really uncomfortable, and we just waited it out together. We went to the coffee shop. She ordered her coffee, was very polite with the barista. We went back upstairs to my office, and she was able to see how she was now much less anxious about the possibility of having that experience again, and found that, yeah, it seemed like exposure work really was helping. And since that session onward, she was able to go to coffee shops, and that became part of her weekly routine. So she was taking walks every day, going to coffee shops a few times a week. She kept expanding her world and started going to museums and bookstores and riding public transportation, and then she got stuck again because she wanted to start calling around and seeing if people had job openings. She wanted to apply for a job. But she just couldn't overcome her anxiety to go in and ask about job openings or to pick up the phone and call. And so, again, after a few weeks of her struggling with this, we decided in session that she'd practice there. And so we sat down and she just felt like she couldn't do it. So what I did was I pulled up a phone directory from Hawaii because they were a few hours behind. We knew the stores would still be open. And she had no intention of ever moving to Hawaii, and so we knew there was no pressure. Regardless of whether these conversations went great or terribly, they weren't actually going to be relevant to her future job prospects at all. And so we worked our way down the list. She called a number of supermarkets in Hawaii, asked them about whether they had any job openings, how to make those applications, and really got practiced with that. And again, felt much more comfortable with doing this when she left the office and was able to take it home and work on it at home. A few weeks after that, maybe a month or two after that, she missed an appointment, which was very unusual for her. She had missed some appointments at the beginning, but then had really been very consistent. And so I called her. She didn't answer the phone. I wasn't sure what was going on, but the next week she came in and she told me that she had missed an appointment because she had been raped, unfortunately. And she was just dealing with the aftermath of that and feeling really ashamed, felt like she had brought it upon herself and didn't want to talk to me about it. But that when she thought about it, really in the spirit of exposure work and the therapy we had been doing, she was feeling really anxious about disclosing this to me, and the right thing to do was to do what felt anxious, and so she decided to come to our next appointment and tell me about it. And it ended up being, of course, a really sad situation, but a really good appointment. So we were able to, first, I was able to repeatedly try to help her wrap her head around the idea that she absolutely didn't bring it upon herself. She was allowed to have a drink without expecting to get sexually assaulted, and that it was entirely the fault of whoever it was that did this to her. We were able to talk about screening for sexually transmitted infections, and she was able to get that done. I was able to discuss post-exposure prophylaxis for HIV and put her on the appropriate medications. And she was able to, again, have this experience of our interaction not being nearly as scary as she had anticipated it being. And then really it was just kind of a hiccup in the course of her treatment. She went back to doing the exposure work that had been working so well for her. I bring this up for a couple reasons. The first one is just the incredible courage that our patients display. This is a woman who a few months earlier had been unable to leave the house because of her anxiety, had been in a previous domestic violence relationship with a man, had been assaulted by a man, and then in the context of profound social phobia and fear of judgment, had chosen to come tell me, a man, about what had happened, despite the fact that she blamed herself for it, and just incredible courage. I think it's also a marker for how well exposure therapy works, particularly once the patient internalizes it. She did something that she couldn't have ever even thought about doing a few months previous, and did it really successfully, and with really good outcomes in terms of her own health, both physical and mental health. Unfortunately, I graduated from residency a few months after that and didn't get to follow her for as long as I liked, but she was really doing well by the time we finished. Now, this time course is much longer than a standard course of exposure therapy, but her situation was also much more severe than a standard case of what I would think would be appropriate for a primary care doc, for example, and I was treating her as a therapist, and that was a much more appropriate setting for the level of severity she had. So let's turn now and look at cognitive behavioral therapy for insomnia. Again, I think this is a very useful skill for a primary care doc to have. Cognitive behavioral therapy for insomnia is highly effective, so studies show that up to 80% of patients will have improvement in their insomnia symptoms. It's often done in the absence of medication. It often allows people to discontinue medication, and it doesn't take as long to be helpful potentially as some of the other interventions, the other CBT and therapy interventions that we've discussed. It is very challenging to get patients to engage in for reasons that we'll discuss. I don't generally draw the CBT triangle when I'm doing CBT for insomnia. It's less important for them to understand the connection between thoughts, feelings, and behaviors, I think, in this case, and really important for them to understand the logic behind the intervention, which is called sleep consolidation. So the target issues are sleep fragmentation and sleep inefficiency. So sleep fragmentation is what it sounds like when your sleep is fragmented. You're waking up a lot during the night. Sleep inefficiency is what occurs when you're spending a lot of time in bed not sleeping. And the behavior, like I said, is called sleep consolidation. And so the focus of the intake is going to be around explaining the biology of sleep and explaining the process of sleep consolidation and seeing if the patient is willing to engage in it. And I will explain it to you so that you can explain it to them. So when I'm thinking about doing CBT for insomnia, I'm going to start by ruling out other potential causes of insomnia and fatigue. And those include mental health causes and physical causes, right? So I want to screen for obstructive sleep apnea, for thyroid issues. I want to screen for depression and anxiety, etc. I want to make sure that what we're treating here is a primary insomnia, because if we're treating a secondary insomnia, really the first important step is treat the underlying issue. Then we're going to do sleep hygiene interventions. So all of your standard sleep hygiene, cutting out all napping is very important. Once I've ruled out those issues and the patient's engaging in sleep hygiene, if they're still having insomnia, then we're going to launch into our psychoeducation. And the psychoeducation, so all animals require sleep, and humans are no different. Everyone requires sleep. It's actually really impressive the lengths to which evolution has pushed sleep. So, for example, there are dolphins in the Indian Ocean. The Indian Ocean is so silty that if you stop swimming, you can choke and die, I guess, as a dolphin. And so they can't ever be fully asleep. So their brain has evolved to sleep for fractions of a second at a time. There are ducks who can't ever be fully asleep for other environmental reasons, and their brain, half of their brain will sleep and the other half is awake, and then it'll switch. So there's remarkable evolutionary adaptations all around the idea that sleep is required. If we look at disorders of insomnia, severe disorders of insomnia like familial fatal insomnia, we see instances where an inability to sleep is actually associated with death. So outside of a very few special circumstances like mania or, as I said, familial fatal insomnia, your body will sleep as much as it needs to. The other thing that's important to know is it takes about 7 to 10 days for a circadian rhythm to adjust to new circumstances. That's why jet lag lasts about a week. When you go to Europe or come back from Europe or Asia or anywhere you travel east-west, your jet lag is going to last about a week because that's how long it takes for your circadian rhythm to reset. So it's really important that the patient understand all of these things to begin with, because what we're going to do is we're going to take advantage of that intrinsic sleep drive in the context of this time frame, 7 to 10 days, in order to design an intervention that will force them to sleep better. So you explain all this, and then you're going to ask them to fill out 2 forms. One is the Insomnia Severity Index, and the other is the Epworth Sleepiness Scale. Now, As I said, I made a Word document that's associated with this lecture, and there's copies of the Epworth and the ISI in that Word document. So the ISI is going to rate how much difficulty the patient has falling asleep subjectively and how anxious they are about their insomnia, while the Epworth rates their amount of daytime sleepiness. There's kind of four scenarios. So you can have a low insomnia severity index and a low Epworth, in which case if you're seeing me about insomnia, it's probably because someone, the media, a friend, a family member, told you that you need more sleep than you need. But you're neither worried about how much sleep you're getting based on your low ISI, nor struggling with daytime fatigue based on your Epworth. And my job in that circumstance is generally to reassure you that all people need different amounts of sleep. There is no consensus on how much sleep any given person needs. And if you are not worrying about your sleep and not feeling fatigued, then you're likely getting enough sleep. And that's pretty much all we have to talk about. Then we have people who have a low Epworth, but a high insomnia severity index. So they're worried about their sleep, but they're not sleepy during the day. Those patients fall into one of two categories. Either they don't really have insomnia, they just have an anxiety disorder, in which case you need to treat their anxiety disorder, or they have an anxiety disorder and insomnia, but they're so anxious that their anxiety is keeping them from being sleepy at night or during the day, in which case you need to treat their anxiety disorder. It may be that you then need to treat their insomnia, but their anxiety disorder comes first. Then you've got patients who have a low insomnia severity index. They're not particularly worried, but a high Epworth. They are fatigued and sleepy during the day. Those are patients who, again, I want to look at other causes, make sure they're not having obstructive sleep apnea or thyroid issues, etc. And then they may be appropriate for cognitive behavioral therapy for insomnia. They may just not be particularly worried, but they're still struggling with daytime fatigue secondary to poor sleep. And finally, we have our patients who have high ISIs and high Epworths. They're sleepy during the day and they're worried about it, and that's kind of the classic patient for cognitive behavioral therapy for insomnia. So you're going to get them to fill those out because they provide useful information. The ISI is 9 questions. It'll take maybe 5 minutes. The Epworth is 7 questions. It'll take maybe 3 minutes. So neither of them are very burdensome. They can fill them out in session. The last thing that I'm going to do during that intake session, I've evaluated them. We've done the psychoeducation, we've done the Epworth, we've done the insomnia severity index, and then I want to send them out with a sleep diary that they're going to keep for 1 to 2 weeks. Now, there's lots of different sleep diaries online, and many of them are excellent. The piece of information that you really need to know in order to do CBT for insomnia is how many minutes the patient is sleeping on average per night. And so I designed this sleep diary because it gives us exactly that information. The ones you'll find online have often many more categories that allow you to calculate all sorts of other metrics, none of which are super useful for CBT for insomnia, but could be very useful in other settings. And so it's just a heads up about why mine looks the way it looks. I'll print out a couple of these, give them to the patient, and ask them to keep this sleep diary for 1 to 2 weeks. And again, I'm going to emphasize that the important piece of information here is the total number of minutes that you're asleep per night, that bottom line. So we need to fill out all the lines above it so we have an accurate bottom line. The last thing I'm going to do during the intake is explain what sleep consolidation actually looks like, because they need to know what they're signing up for. And this is what it looks like. So once they bring that sleep diary back, I tell them, what we're going to do is we're going to average the total amount of time that you're asleep every night over the course of the 1 to 2 weeks that you keep this diary for. And then we're going to add 30 minutes to that average amount of time. You're going to pick a bedtime, and a wake-up time that spans your average time plus 30 minutes, and that is the only time you're allowed to be in bed, and you are not allowed to sleep any time outside of that. So for example, if you come in with your sleep diary and we calculate that you sleep an average of 5 hours a night, then you will get a 5.5 hour period of time per night during which you get to be in bed. Patient may say, okay, I want to be in bed then from 11:30 p.m. until 5 a.m. That's my 5.5 hours, and they need to hold themselves to that schedule. I'm going to explain to them why we're going to do this. So their initial reaction is accurately going to be, I'm going to be exhausted if I do that. And they are going to be exhausted. And after 7 to 10 days of adhering to that schedule, their circadian rhythm is going to reset. They're going to get more and more tired over time. And as any of us can attest, it becomes easier and easier to sleep as you're more tired. And by the end of that 7 to 10 days, what they're going to experience is they're going to be asleep for all 5.5 hours that they are in bed. They're going to come back in and tell you how it went. And it's very likely that if they actually adhered to it, they're going to be sleeping for all 5.5 hours. And then you're going to add another 30 minutes for 7 to 10 more days. And they're very likely to sleep all 6 hours by the end of that 7 to 10 days. And then you're going to add another 30 minutes. And then you're going to maintain that for another week to 10 days. And then you're going to repeat until either the patient is sleeping well and satisfied with their sleep, or until their sleep fragments again. If it fragments again, you can wait it out for a week. You can reduce it by 30 minutes and hang out there. And the thing to understand is usually sleep fragmentation at that point is a signal that they are now getting enough sleep. They're getting the amount of sleep that their body needs. If they're still having daytime fatigue, then you want to again go back to looking at other causes. If they're still having a lot of worry, you want to go back to looking at their anxiety. Most patients are going to respond to this proposal by telling you how exhausted they're going to be. And the thing to understand is that they are right. So if they're spending 10 hours in bed to get 5 hours of sleep, their sleep efficiency is only 50%. And on that first day, when they limit themselves to 5.5 hours, their sleep efficiency is going to be 50%. Their body's expecting to have 10 hours to sleep in. And so they're going to only get 2.5 hours of sleep, and they're going to be tired. And the next day, they're going to sleep a little higher percentage of that. Their sleep efficiency is going to go up because they're tired, but they're still going to be very tired. And that's why it takes 7 to 10 days to push that circadian rhythm to reset. Now, it's important to remind them that by the end of the first week, they're going to be getting as much sleep as they're getting before they came in. And so they're going to be tired, but they're only really going to be tired for a week. And they're going to be sleeping much more efficiently and much better. And after that, really it's all improvement from there on. I've had many patients who say, I just can't do this. And then I say, I understand. Come back when you feel like you're ready. We do motivational interviewing and try to understand what role it would play in their life if they were sleeping better, etc. I've had patients who say, I can't do this right now. I need to take a vacation from my job in order to be able to do this because I just can't afford to be that exhausted. I had one patient who was a trucker, and I told them, you can't do this until you take a vacation. Like, I can't help you do this in good conscience because it's just dangerous for other people, and I can imagine other professions that might merit that. I've had patients who say, I need to arrange for some babysitting for my kids if I'm going to do this for a few days. That's reasonable. And so you want to accommodate them around this. But the message is, this is hard, but it works. 80+% success rate in studies. And most people intuitively understand, yeah, that will work. From the perspective of the primary care doc, this is time intensive initially, just like any of the other CBT for insomnia or CBT interventions we've discussed. So I usually do an hour intake during which I'm going to assess them for other causes of insomnia, make sure they're doing good sleep hygiene, have them fill out the Epworth and the ISI, explain the sleep consolidation process so that they know whether they're interested in doing it or not, and if they are, get a sleep diary. That's all session 1. Session 2 is probably half an hour during which we're going to add up the time and then actually come up with a plan in terms of this is the number of hours I'm going to be in bed per night for the next week or week and a half. Reinforce the sleep hygiene and reinforce that motivational interviewing to help them actually do it. Session 3, we're going to check in on how it went, add 30 minutes, rinse and repeat. Session 4, session 5. It usually only takes maybe 6 or 7 sessions before they get to the point where they're sleeping the whole time they're in bed, feeling less fatigued, and you don't really need to continue doing this. Just like with other CBT, you are giving them a tool that they can use themselves without the support of a therapist in the future, should this continue to be an issue. So before we summarize what we've talked about, I want to finish up with a few more points about CBT for insomnia. The majority of patients, I recommend that they stop any sleep aids before we start this process. And the reason for that is that the process is going to help them to sleep regardless of whether they're taking medications or not. It'll work for someone who's taking sleep aids. It's just that at the end of doing it, if you stopped all your sleep aids, you'll be sleeping well without sleep aids. And if you didn't, you'll be sleeping well with sleep aids. And if you then want to get rid of the sleep aid, you'll need to do another cycle of sleep consolidation because you'll stop the sleep aid and then that'll disrupt your sleep cycle and you'll need to again restructure your circadian rhythm to adjust to not having that sleep aid. And I usually just tell people, if we're going to do this, let's just do it once and get it over with. Let's stop the sleep aid before the sleep diary because that's going to impact our ability to do accurate math. Then we'll do the whole process without the sleep aids and we'll train your body to sleep well without them. Like other forms of CBT, most patients benefit more from the behavioral intervention than the cognitive intervention. And the cognitive intervention in CBT for insomnia, just like other forms of CBT, is cognitive restructuring work. It tends to focus on anxiety around difficulty sleeping or the consequences of sleeping poorly. And like other cognitive restructuring work, I think it lies outside the scope of primary care. But 80% of people will respond to CBT for insomnia, and of those people, 80% will respond to sleep consolidation itself. And so I always start with sleep consolidation, and I think that that is certainly something you can do in the primary care setting. Again, it's time intensive to get started, but probably in some circumstances easier than trying to help a patient navigate complex conversations around various sleep aids for years or decades to come. Now, looking at a summary of these CBT interventions. So we talked about behavioral activation for depression, we talked about exposure work for anxiety, and sleep consolidation for insomnia. We also mentioned cognitive restructuring as the cognitive component that accompanies each of these. That cognitive restructuring might look different in each of those circumstances, but in general is beyond the scope of primary care. My experiences are that through all of these behavioral interventions, it's hard to get patients started. There's a lot of motivational interviewing involved, and there's a lot of just helping the patient to get to the point where they're doing what they need to do. It's hard for depressed patients to activate themselves. It's hard for anxious patients to engage with that anxiety. And it's hard for people who are sleeping poorly to risk sleeping even more poorly in the short term in order to improve their sleep in the long term. So it's hard to get patients started. Once they get started, all of these interventions work fairly quickly, especially when we compare them to medications. All of these interventions become self-perpetuating for a few reasons. The first is that all of these offer patients a sense of control and a reality of control over this issue that they're struggling with. It's very empowering to realize that you can fix your own depression, you can fix your own anxiety, you can fix your own insomnia. And that helps people to feel better and is very empowering, and so it becomes self-perpetuating once they start to see benefits, which you can help them to see those benefits by again reinforcing the connection between the behavioral change and the outcome that you're looking at. It also becomes self-perpetuating because all of these issues are very aversive. Depression, anxiety, insomnia, nobody wants to be suffering from those. And once people realize that they don't have to be, that they can at least improve, if not resolve those issues based on the things that they choose to do, well then they're very likely to choose to do those things to help resolve those issues. And finally, CBT is durable. You're teaching people skills that they will be able to use even if they're not in therapy in the future. And I've had patients who will come back to therapy who've done a course of CBT for, we'll say, anxiety, depression, insomnia, it doesn't matter. For any of these things, they've done a course of CBT, they really were successful, got to the point where they resolved the underlying issue, then had an illness flare or fell back into bad habits or something happened. So for example, in the COVID circumstances now, it's really exacerbating a lot of people who have social phobia because they're not able to go do the exposure work that helps prevent that from getting worse. And so, we get people who come back in for essentially just booster sessions. They say, I remember how to do exposure work, but I really need someone to help me get started and to help me troubleshoot for a couple sessions, and then I can take it from there. And often that's exactly what happens. And so this is helping people to develop durable tools that they can use in order to address these issues. I want to thank you all for joining me. I hope that this has been helpful. I encourage you to reach out if there are any questions, and I appreciate your time.